At least 30% of antibiotic courses prescribed in the outpatient setting are unnecessary. Most of these antibiotics are prescribed for acute respiratory conditions. More than half of all patients who receive a diagnosis of an acute respiratory tract infection are given an antibiotic prescription, despite the fact that an overwhelming proportion of these infections are caused by viruses, not bacteria. Let's consider a few common acute respiratory infections and some implications for antimicrobial stewardship. First, sinusitis. Less than 2% of episodes of acute rhinosinusitis are caused by bacteria. However, antibiotics are commonly prescribed. An analysis of 2010 to 2011 national survey data found that sinusitis was the single most common diagnosis associated with an antibiotic prescription in the U.S. Robust clinical data has shown minimal or no benefit of antibacterial therapy in most patients with acute rhinosinusitis. Evidence suggests that between 7 to 8 patients need to be treated to achieve clinical improvement in one patient, while between 8 to 12 patients need to be treated for one patient to experience harm from the antibiotics. This means that empiric antimicrobial use in sinusitis is as likely, if not more likely, to lead to harm as clinical benefit. Moreover, a large cohort study in the UK found that a reduction of antimicrobial use for URIs was not associated with an increase in the uncommon but serious complications that clinicians often hope to prevent by prescribing antibiotics, including meningitis. So, withholding antibiotics from some of these patients is safe. National and international guidelines do support the use of antibiotics for acute bacterial rhinosinusitis. Unfortunately, an accurate diagnosis of acute bacterial rhinosinusitis as opposed to viral sinusitis cannot be made on clinical criteria alone. Furthermore, plain X-rays and CT scans cannot distinguish bacterial from non-bacterial causes of rhinosinusitis. 87% of adults with typical common cold symptoms have maxillary sinus abnormalities by CT evaluation. Frontline clinicians are often forced to make decisions regarding the empiric use of antimicrobials with imperfect clinical data. The Infectious Diseases Society of America guidelines suggest the empiric use of antibacterials be reserved for patients who fit the following criteria. Number 1, those with persistent symptoms or signs of acute rhinosinusitis lasting for greater than or equal to 10 days and without any evidence of clinical improvement. Number 2, those with the onset of severe symptoms or signs, including high fever, purulent nasal drainage, or facial pain, lasting for at least 3 to 4 consecutive days at the beginning of the illness. Or number 3, those with a presentation consistent with double sickening, meaning patients with worsening symptoms after a typical viral URI that lasted 5 to 6 days that was initially improving. Some guidelines, including those from the American Academy of Otolaryngology Head and Neck Surgery, suggest that either empiric antimicrobial use or watchful waiting for patients with clinical symptoms suggestive of acute bacterial rhinosinusitis. Canadian and European guidelines also include watchful waiting as an option, especially for those with non-severe symptoms. Experts encourage the use of shared decision-making with patients in these scenarios. For more information regarding shared decision-making, please see the references at the end of this segment. If empiric antibiotics are indicated, high-dose amoxicillin clavulinate is the recommended first choice. Despite this, data suggests that clinicians more commonly prescribe non-first-line agents, of which macrolides are used most frequently. The high frequency of resistance among strep pneumoniae precludes the empiric use of macrolides, trimethoprim sulfamethoxazole, or oral cephalosporins. Doxycycline may be an effective alternative for adult patients. Respiratory fluoroquinolones should not be routinely used for acute rhinosinusitis in concordance with the 2016 FDA advisory. Routine antibiotic coverage for methicillin-resistant Staphylococcus aureus is not recommended. Although the optimal duration of therapy for acute bacterial sinusitis is unknown, guidelines recommend a total of 5 to 7 days of antibacterials. Adjunctive therapy with nasal saline irrigation and intranasal corticosteroid administration, especially in patients with allergic rhinitis, is also recommended. Data suggests that these measures provide greater symptomatic benefit than antibacterials, even in bacterial sinusitis. decongestants, and antihistamines are not recommended. Let's briefly review two other common upper respiratory tract infections, pharyngitis and bronchitis. The majority of patients with sore throats have viral infections. However, an estimated 5 to 15% of cases are due to group A strep pharyngitis, the only cause of bacterial pharyngitis for which antibiotic therapy is recommended. Despite this, up to 60% of adult patients with sore throat are prescribed antibiotics. The stewardship principles that apply to pharyngitis are as follows. Number 1, only patients with features suggestive of group A strep pharyngitis, such as persistent fevers, anterior cervical adenitis, and tonsillopharyngeal exudate, should undergo rapid antigen testing. Patients with clinical features suggestive of a viral etiology, such as those with cough, rhinorrhea, hoarseness, or oral ulcers, should not be tested for group A strep. Number 2, only patients with confirmed strep pharyngitis should be treated with antibiotics. Penicillin or amoxicillin are the first-line antibiotics for strep pharyngitis. In the absence of penicillin allergy, second-line agents such as macrolide should be avoided. As with sinusitis, however, second-line agents are commonly inappropriately prescribed for strep pharyngitis. An estimated 10 million healthcare visits for acute bronchitis occur annually in the U.S., and antibiotics are administered in up to 80% of these encounters, despite the fact that as many as 95% of these cases are non-bacterial. Acute, uncomplicated bronchitis should be distinguished from other causes of acute cough, such as common cold, influenza, acute exacerbation of chronic bronchitis, and acute asthma. Clinical trials of antibiotic therapy have failed to demonstrate clinically significant benefit, and as a consequence, should not be administered to patients with acute uncomplicated bronchitis. Clinicians should consider the possibility of pertussis in those patients with a cough of several weeks' duration, with the recognition that although antibiotic therapy does not alter the clinical course, it may reduce transmission. In 2016, the American College of Physicians and the Centers for Disease Control and Prevention provided high-value care advice for frontline clinicians managing patients with acute respiratory tract infections. They include the following points that highlight the stewardship opportunities within these diagnoses. Number 1, do not perform testing or prescribe antibiotics to patients with bronchitis. Reserve antibiotics for those with suspected pneumonia. Number 2, only prescribe antibiotics for confirmed cases of strep pharyngitis, and reserve rapid antigen testing for those with signs and symptoms strongly suggestive of strep pharyngitis and not suggestive of a viral infection. And number 3, only prescribe antibiotics for rhinosinusitis in concordance with national guidelines. These 3 common infections are great targets for stewardship interventions in the outpatient setting. Programs have sought to reduce the use of antibiotics through education, clinical decision support tools, and provider feedback. Given patient pressure, real or perceived, for antibiotics, effective communication strategies are critical to frontline clinicians discussing antibiotics with their patients. We discuss some of these strategies in detail in our companion course directed at outpatient clinicians, including the mnemonics shown here.